and and they're the ones that are more at risk for events like passing out, as well as developing admissions for heart failure and for inability to really their quality of life, their ability to do normal activities without becoming extremely breathless, depending on how severe the obstruction is what we often see. But the non-obstructive people can live many years and develop an obstruction or not. I mean, and be okay. There are certain times where particularly diastolic abnormalities, are you familiar with? Where they have filling problems and they develop fluid overload with regard to because their ventricle's so stiff that fluid backs up. But the obstructive patients are the ones that really start to develop. Really, the ones that I'm mostly referring to in this circumstance.
Understood. And could we move to mavacamten? So the company has presented some data, and I just wonder what were your general thoughts when you saw the data, the trial design, the outcomes? What was your takeaways?
Yeah, so I mean, I've been following just from an interest because it's kind of like an orphan drug. This or not an orphan drug, but a very selective drug. That targets a particular gene, and that's implicated in the disease progression of hypertrophic cardiomyopathy. And I've been following it since kind of like the early phases, and the data was pretty good. I mean, it definitely showed that there was improvement in a number of in their exercise gradients and their symptoms, and it was overall it was very, very good data, I thought. But I guess the thing that I felt that what I'm not sure about is whether or not it actually reduces disease progression, meaning that it was targeted to reduce the progression of hypertrophic cardiomyopathy as a disease entity, but it just is basically an adjunctive therapy to reducing the obstructive symptoms, if that makes sense.
Right, understood. But it's interesting. So if I look at the phase 3 trial, that company, I think they initiated it in March 2018. So this is 220 patients, symptomatic obstructive HCM adults. So their primary, and it's very interesting. So their primary endpoint is a percentage of participants that are achieving a clinical response, and clinical response they define as an improvement in symptom severity from baseline to week 30 as assessed by New York Heart Association function classification. And so that's so I'm wondering that what you said on the disease progression, I wonder if that outcome that they're trying to measure within the phase 3 trial is sort of reflects your question.
It does. I mean, I kind of guess there. I was hoping that there would be some incorporation of a measure of, actual prevention of further cardiac fibrosis.
what is it possible? Is it actually reasonable to think that any influence on the ejection fraction based on the mechanism of action?
Well, they've looked at an early phase trial at fractional shortening, which is more of a science. It's more of a academic measure. We don't actually use it in clinical practice, but you hope it doesn't reduce the ejection fraction per se. I mean, you want it to reduce the contractility, but I guess it may reduce the ejection fraction maybe 5% or so, but that's not really what you're looking for. It's, I guess it's kind of it's a little bit of a discrepancy. It's a little bit of a, I don't know how to explain that without saying, with every effective beat, it's not as strong, but it doesn't necessarily affect the amount of fluid that goes out. Does that make any sense to you?
Yeah, it does. It's very interesting. I'm looking at the trial design at the moment. That trial with symptomatic obstructive HCM, and I'm looking at the patient inclusion criteria, and they are enrolling patients that have New York Heart Association classification stage 2 and 3, class 2 and 3, and they have documented left ventricular ejection fraction more than 55%, and they have documented oxygen saturation at rest more than 90% at screening. And I'm just wondering, is it really representative of the patient population you work with?
They have you said New York Heart Association class 2
and 3
at least, right?
Two and 3, yeah.
Yeah, that's representative of the obstructive population, of course. Yes.
Right.
And that's very accurate for the obstructive population.
And do you, in terms of the side effects, are you comfortable with this drug?
The side effects, I haven't heard too much about the side effects of the drug. I mean, if you can refresh me on them, there hasn't been too many as far as I'm aware of.
No, it was relatively clean, but there was some sort of, and I haven't checked it yet, but there were some rumors at the beginning either the drug will kill patients or will be totally safe. I haven't checked the origin of the statement, if you see what I mean. But so far the data that was reported was clean. But I'm just thinking if you've heard anything.
Certainly, I mean, I'm not sure what ended up, happening with those types of statements, but at least from the statement, from what was recently released with, the American Heart Association, I don't recall any significant adverse events.
No, nothing.
I mean, obviously that would be a major, detriment to the drug and to the trial of the drug, but I don't recall anything. And I guess you have to remember that these patients, one of the side effects would be not treating them, and that any therapy afterwards would be. I mean, it's easy to say, but when you're trying to invest in something, you want to know it's safe. But these patients need some other form of medication, otherwise they're going to something more aggressive, which can certainly have, high morbidity and mortality.
And could I ask a slightly theoretical question? If we assume at some point in time